But for 20 solid years, nobody ever mentioned to them that they valued what he was doing. So they went to his accounts, they were clean, his house neat, but in his body there was a note. He said, man, for the 20 years I've worked here, nobody has ever appreciated my services. I don't think I'm needed around here. He committed suicide. We shouldn't do that. Last but not least, there has to be an interprofessional collaboration. When we train these individuals, be they nurses, be they doctors, whoever, let them know they cannot serve patients on their own. There has to be room for people to collaborate. And our ears must be open 24/7. Last week we had a patient that was vomiting post-operatively. And naturally, we say the ondansetron will be the best thing. Yeah, 5-HT receptor antagonist. He was given. Half an hour later, vomited. Oh, okay, fine. In that case, then do dexamethasone. 30 minutes later, and then a humble nurse whispered to me, Dr. Mpoke, mmejaribu metoclopramide. I said, ni hiyo. We gave that medication, the patient stopped purine, they ate, they felt strong, they left. Knowledge-based practice is the motivation for capacity building. I believe when these 10 points are put together, we shall have better staff offering services in critical care settings. Thank you very much for your time.
Ladies and gentlemen, let's put our hands together again to Dr. Mpoke for a wonderful presentation. Doctor, I just want to say a few things before you leave. Just bear with us. Just a few things. They say in Swahili, tukupe maua yako. So I picked a few things from your presentation, and I want you to hear this. Some other professions, not people from EM and critical care units, they normally have the husband and wife at work. Do you recommend that for our staff? For the passion and compassion that you have been explaining? I'll leave that for the discussion. And to allow you to go, there's a machine I came across. It's a quantum magnetic analyzer. And one of the areas it analyzes is the human conscious levels. I was surprised to see that machine can analyze our level of happiness, peace, joy. I believe such machines can be available also for our staff and help them understand their feelings after tireless shifts. I allow you now to take your leave. Let's put our hands together again for Dr. Mpoke. I had made 4 points for Dr. Mpoke. I'll finish the 2 with you guys. One extra point, he spoke about recognition at workplaces, and he spoke the point where we post pictures. I know when we take this discussion to our departments, it might take a lot of time. Let's start by posting our own pictures on the walls, and then the discussion will follow. Ladies and gentlemen, up next is our beloved Dr. Ramadhani Chunga, and he's going to take us through a very nice presentation on the ultimate chain of saving lives and the thin line between emergency medicine departments and critical care units.
Good afternoon. Is there any, we are all in Tanzania. Do you see the difference between ICU and emergency medicine department? Do you see any difference? Probably not. But do all these machines help us to save lives? Does a critical care unit really matter to the number of patients that come to hospital? Probably not. Do cardiologists, emergency physicians, and maybe neurosurgeons that we produce are enough in saving life? So let's look at the ultimate chain of saving life. Well, sometimes when things happen, actually we cannot hide. We cannot hide to succumb anything. Emergencies happen everywhere. You cannot hide. You can go to wherever you want to go, but emergencies can happen. But whenever it happens, wherever it happens, things must be done to save a life. So we must suit. Our system should be created to suit that. Whether it's under the car, in the ocean, in the plane, wherever, there must be a system to resilient enough to save a life. So you can see how much capacity we need to build. Do we have people that can save a life in the road? Not yet. Do we have people that can save a life in the ocean? Yes, but not yet. We have seen the issues happen in Mwanza. The person who was congratulated for saving a life was not a doctor, was not a paramedic, was just a person. We are physicians. We should be the one to do that. And therefore, we should capacity build to fill in that gap. And there are so many circumstances that we can see that we can capacity build and help to sustain life. Well, we'll be talking about peri-arrest. We'll be talking about high-quality resuscitation. We'll be talking about post-cardiac arrest care. These are important elements. And to be honest with you, I'm not talking about cardiac arrest. Because whenever anything happens, our body tries to compensate. And when compensation mechanisms fail, it will decompensate, and further, something more will happen. Our job as clinicians in every way we go is to make sure we identify compensatory mechanisms that the patient comes with, we resuscitate, and the person will go into the right direction. What does that mean? If that's the case, who is the most important person in saving life? Let's look like that. Let's imagine we don't have any person that we know has got any HE, any T's that we know about. Who do we need the most? Looking at the chain of saving life, we say the most important part is surveillance. Surveillance is monitoring. Let's say we do have a patient who is in the ward. This person was admitted either from theater or was admitted for pneumonia. What do? We ask a nurse, please can we chart vital signs every 4 hours? Or sometimes every 2 hours, or 1 hour, or in ICU every minute. That is surveillance. And usually that means the system should allow that if things don't go in the right direction, the physician, the nurse, or the doctor who is on call or who is with the patient is activating emergency response to respond to that situation. Failure to that, the patient will decompensate. So surveillance becomes key to everyone. And this surveillance can be pre-hospital when the person is home. That's why you see patients are saying, say, every 2 weeks come to hospital, I need to see you. The OPD is a surveillance system. You need to have a patient who comes in and you can check if things are not going well. Sometimes you have to do electrolytes. For example, though dialysis patient, you have to check for potassium, you have to check all these things. So you're doing surveillance. Similarly, we have got clinics, wards, waiting rooms. We do have patients sometimes in waiting rooms and they die. If you don't have someone to watch them, they may be hypotensive, they may collapse there because of their patient. So we need also to provide surveillance in waiting rooms. Moving forward, let's say someone comes to hospital and has shortness of breath or anything that made them to come to hospital. The key to saving or providing care is actually identifying what is actually the problem. Because a shortness of breath, you know, if I ask you, it could be pneumonia, it could be acute coronary syndrome, it could be just anxiety, it could be anything. But the treatment of anxiety, the treatment of acute coronary syndrome, the treatment of pneumonia, the treatment of pulmonary edema is quite different. The power to the doctor or to the treating physician is to recognize that this person has got acute coronary syndrome. So if we recognize, immediate recognition helps into early resuscitation. Most of the problem, we lose our patient because of late recognition and late resuscitation. And sometimes we treat complication because of late treatment. And this is, you can see, someone come with diarrhea in the hospital, has lost a lot of fluids or is vomiting, a loss of fluids. We are unable to identify the hypovolemia. We are unable to treat the immediate complication, acute kidney injury. And what is going to happen? This person is going to go to a long-term kidney injury, into CKD, and in the end, the person end up into requiring dialysis for the rest of his life. So, key here, early recognition of hypovolemic state, rehydrate with the fluids, check creatinine how it goes, and then in the end of the day, you will come up to see this person, and usually it will resolve very quickly, and you see the person can be discharged healthily home there than requiring dialysis. Then, after early resuscitation, then sometimes you need advanced life support as well. For example, we do have a person come in, have got abdominal pain, is vomiting. You have checked everything. This person does not acute coronary syndrome, does not have anything. You think this person has got appendicitis. And then definitely you appropriately consult or with your physician and all surgeons, and then we agree that this person requires surgery. Surgery is advanced life support. It's not a basic life support. Basic life support is to give fluids, to resuscitate this person if he is hypovolemic, to assist with this person with pain, and all these are basic maneuvers. But advanced is when the surgeon comes in, that's advanced. Not everyone can produce. So that's the intervention we're talking about. If you're talking about a person who has got acute coronary syndrome, then rapid intervention is to get this person to cath lab. If you're talking about a person who is having like the surgical issue, to go to surgery. As you can see, the first three links of saving lives, anyone in this room, irrespective of you are a specialist, you can do this. You don't need Dr. Fire to do that. And mostly, you need a nurse at some point, you need a family member most of the time, okay? You need an ambulance provider, you need a junior doctor, and ward teams. And I can tell you, these are the back of our system. Specialists, you can have 2 or 3 specialists for the whole hospital. You can have 3 or 4 emergency physicians or 1 emergency physician for the whole hospital. But most are nurses, junior doctors are the ones. So if I ask you, where should we invest more? Where should we capacity build more? we should capacity build non-specialist people in our hospital. We do have people who are actually porters, for example. Do you think a porter cannot help us with the CPR? Can do. Do we train them? We have got radiographers. If someone collapses in radiology, who does help? It is a radiographer. Do we actually train them to assist us when you know what has happened sometimes? People, EMD people, please come. They're at radiology. Someone collapsed. We don't have that time, that luxury in saving someone's life. So it means everyone around us should be observer. I can also give you more important example. Our own family, our own wives, our own husbands. At night, you have acute coronary syndrome, chest pain. What do you do? What do they do? You know what they do? Oh, I think you need something to drink. They bring you water. Because always in our society, people have got reasons for everything. They provide, I think you did not eat. Someone is having kiunguria or is having it's PUD. But actually someone has got inferior MI and he actually is going to die. That's why you can have, if we do research, and this is what has been called upon by Dr. Mkop, we should do research. We should answer our own questions. We should not be answering questions from America. How many times you receive people who died from home? How many times? Maybe a lot of time, someone died at home. No one dies at home because of appendicitis. No one dies home because of diarrhea. People die home because of simple things. And probably acute coronary syndrome. But we have been told since, oh no, it's only malaria here kills people. No, there is acute coronary syndrome, even to kids. Go to JKCI. Find the data from JKCI. Find data to cath lab areas. They will tell you more. So let's go back and train our families, even to smaller things. Ban. I also sometimes say, you know what? I'm emergency physicians here. My wife is a emergency physician. You are maybe a critical care specialist and whatever. But who is taking care of your child at home? You've got 2 beautiful children. But these are taken care by someone who came from there, in the village there. There's no even trained personnel who's taking care of a professor who's working in the university. You know what happened when they're feeding porridge? When the child does not want to eat, you know what they do? They close the nose. You know what happened? These 2 systems are so intelligent. Epiglottis is very intelligent stuff. And by doing that, you're confusing it. Because when you swallow, actually it closes. Right? And when you talk, it opens. When the child is crying, it means it's opened. So when you're throwing food, there is a chance of going to the airway. So what are you doing? So that's what I'm saying. We need to invest capacity build, not only us, even to our families. Burns. You know what happens when someone is burning? When burn is exposed to the skin, it penetrates through to the bone. That's why you get layers. So the most important thing when a burn happens, to cool. But what happened? People take mayai. What is asali? What is asali doing? Thank you. Okay, so then the rest of the system is the advanced providers. The advanced providers, these are JKCI, cath lab, they provide a very small part of care. And when you talk of quality of care, you are talking of these people here. These here are usually very good. That's why I can tell you, if you go to JKCI or a facility of the like, people appreciate going there because specialists are not as other people. Because usually knowledge means a lot. When you know, you cannot be rude. When you know this person is sick, you cannot be rude. But when you don't know, how come someone anajifanyisha afu aje saa 6 usiku nyumbani, aje saa 6 usiku hospitali? How come someone akajifanyisha akaja saa 8 usiku? People don't want to sleep. When you see someone coming at night, this person is sick. Your mood and your attitude towards that should reflect that this person is in trouble. You need to assist. Even if you don't find it, you say, no, I've checked this, I've checked that, but I didn't find anything. But this person, let me admit, I need to check on this tomorrow. It's not a person for admission. It's not a person for discharge. I only discharge a person that I know what is going on. I don't discharge a person who comes in and I don't know what is happening and is having a chest pain. There must be some things hiding. So keep there, get the mind fresh. Your colleague you're going to see in the morning, then you can be discharged. You can even admit in the ED, in the emergency department. That's why there is a concept of short stay wards in the emergency department, which we can talk about that. And we can have that a different view. So I want to welcome you, my colleagues, that these principles, let's capacity build our team, and especially those colleagues who are emergency physicians here. Let's train your teams, train people that are working close to you, and that's going to be very good, and it's going to work very well. Basic life support always is where everything happens. If you fix the basics, advanced things won't come. And that I don't mean cardiac arrest. Cardiac arrest is not something that we should be speaking about, because when someone goes to cardiac arrest, something failed, either monitoring, resuscitation. So we're not talking about the failure. We're not trying to fix our failures. We want to fix before the person collapses. So we're teaching you BLS, we're teaching you, but we're not teaching you that you should wait a person to die, you do chest compression. After all, you need 6 people to be on one patient to have this person have pass back. But these people is a lot. Why should you spend all that time? But only one person can resuscitate the person, come back into a normal self without needing all other sources. So basically, we spoke about all these things, and it has been covered in the lessons that we are doing, and the importance of chest compression. We spoke yesterday, and we also today, some of you are in the SLS and the PALS, and many that are involved in airway management and ECG interpretation, but most of the time you don't want to follow your patient to the grave. There's a time you have to say, no, this is enough and enough, but let's reach this time when everything has been done. Thank you so much.
Let's put our hands together once again for Dr. Ramadhani Chunga. Thank you very much, Dr. Rama. 2 points I picked from your presentation, wonderful presentation, was you have a wife who is also an MD physician. That is all I'll take home with me. I urge all those singles and aka bachelors, do not be senior bachelors. Get a wife or a husband from your department. It will ease your work, but also taking care of home shifts. And the second item that I picked was the seriousness when patients present at the emergency department in midnight. I worked at a certain hospital sometime many years ago, my friends. And I remember my colleague were doing shift together, and what we decided was whoever comes to the hospital past midnight, they should not go home. Regardless, you have tested, diagnosed, allow them to stay for observation, at least for the next 8 or 12 hours. Okay? So doctor said, don't take it as at ease. If somebody presents at emergency department in the middle of the night and you just take it easy. They could not sleep at their homes, means they found a bed at the hospital. Please give them those beds. Once again, thank you very much, Doctor. My dear colleagues, as we wind up our afternoon session, day 2, I would like to invite our dearest friend and colleague also in assisting our patients and taking care, improving quality and also service provision. An occupational therapist, Our dearest Mr. Godfrey Kimati. Please, let's put our hands together as he approaches.
Hello. How are you? Ramadan Kareem, everyone. My name is Godfrey Kimati. I'm an occupational therapist from Muhimbili National Hospital, and I'm very happy to be here with you. Very proud to be in front of Dr. Fire today. So my first question to you when I was coming here, I was thinking, where would I start with this presentation today? Since most of you might have heard about occupational therapy, but as well confusing it with physiotherapy, sometimes with behavioral therapy. But today I wanted to at least enlighten you about what occupational therapy really is, and especially in critical care. So the first question to you, when you wake up today in the morning, was there someone who helped you to get off the bed? Someone who was helped to get off the bed today? Is there anyone? No. Is there anyone who was helped to brush their teeth today in the morning? Anyone? Is there anyone who would like to be brushed their teeth? Someone who would like to be brushed their teeth? Someone to be combed their hair? Someone? The lady here. Nice. So from this population, only one lady would like to be combed their hair, but the majority of us would like things to be done by ourselves, right? You'd like to be doing things by yourself. Now, when we are talking about occupational therapy, it's about things that you do from the time you wake up to the time you are going to sleep. That's occupation. So imagine about your patient who is actually being attended by you at the clinic, actually at your clinic, or has come for critical care services. Are they comfortable for things to be done for them? Start to think about that. When they've had maybe incontinence, are they happy for such situation to happen to them? And when you are thinking about that, try to put yourself in their positions. Now, when we are talking about occupational therapy in critical care services, we are looking about when a patient has suffered and is being attended for critical care, there are several things that they start to experience. One, they may have suffered about their muscle weakness can start to deteriorate their muscle capacity, and occupational therapists would really help this patient from the foregoing to ensure that they equip their muscle strength before it deteriorates to a point whereby it will lead to disability. That's the first thing. Another area where these patients who are coming to us for critical care, another area where they may be affected is their cognitive function. I do believe you might have faced patients who have suffered they are going to have cognitive impairment, and at this early stage, this is when occupational therapists would help this patient to ensure that first they assess their cognitive function, and second, they start to do interventions that will equip their cognitive function from deteriorating. Another area where these patients that we receive for our critical care services, where they may inquire to have occupational therapy interventions, is when they start losing their functional skills. I do believe patient that you see, you may be ordering a nurse, maybe go turn the patient every after 2 hours, yeah? Make sure that the patient is being fed. But have you ever thought or think that the feeding skill will be lost by the time this patient is being discharged from your critical care services? So by the time this patient is being attended for critical care services, they may be requiring to ensure that their functional skills are being maintained, and functional skills about everything that you are doing from the time when you wake up. How do you pick your clothes? How do you put them on? And how do you get out of the house? All these function, by the time this patient is being admitted at the hospital, there is a chance that it may deteriorate and they may lose these functions. So you need to have when you have an occupational therapist in your team, they will work with you to make sure that these functions have been maintained. Another area which occupational therapists will work with you is on the area of self-care. How often in our critical care services do we see our patients brush their teeth by themselves? How often? Does the nurse does that? Would the patient want to do that by themselves? Have you ever had a patient who can have the skill to do that by themselves? So these are the questions that you need to ask yourself while you are at the critical care services to ensure that this patient, by the time that they are there, their dignity is being maintained, their sense of worthiness is being maintained. So another area that I wanted to make a little bit of insisting on is on the area of cognitive function, which I had said a little bit. Our patient, when they have effect happens in their cognitive function, they may lose several factors. One, they may lose their sensory motor skills, they may lose their fine motor skills, and this is a point where an occupational therapist can really help to maintain this function from being lost. And finally, one area that is of importance that I wanted to talk to you, it's about the area of sensory processing. So sensory processing, it's about how you receive your senses from the environment through your sense organs and how you process it to have a good, proper outcome from how your brain has processed the information that has been received. Now, one among the issues that we see in patients who have been long time admitted in critical care, its effect on their sensory processing. So now we know we have 5 senses that process and receive our stimuli and process it to get feedback. But as well, have you ever seen a child who has been long time admitted for critical care services, and once has been discharged, you see parents start complaining that my child has lost their speech skills, my child has lost their fine motor skills, right now is more hyperactive. Have you ever heard of such information from your parents, from your patients? So these are the kinds of interventions, if they were done earlier while the child was still at the critical care unit, would have been addressed prior and to maintain those functions. Because our senses, yes, we see 5 senses, but there are other senses like vestibular processing skills where the kids who have been in the ICU or have been in critical care for longest of time, they may have suffered from losing their vestibular skills. So they will need to be maintained when they're still in the critical care units. As well, to adults, they may reach a point by the time, if the patient has had NGT for the longest time, they may lose their speech skills, but by the time while this patient is still at the critical care, when the sensory intervention is being done to them, may have higher chance to maintain their speech skills. Another area where you may find our patients are suffering from in sensory integration is their proprioceptive skills. You and I right now, our brain feels that we've occupied space through our joints, our muscles, our tendons, but by the time this patient has been admitted for the longest time in the ward, they may start losing their proprioceptive skills, whereby if you include the occupational therapist while this patient is in critical care, the chances to maintain their proprioceptive skills could have been higher, and by the time this patient has been discharged, the proprioception, feeling their body in position, will be maintained. And finally, one area of importance that I wanted to insist for engaging occupational therapists in your critical care services is on the transfer of the patient. Training patients, proper transfer while they are still in the critical care services. This can be transferring from bed to sitting position to lying position, to ensure that the patient does not succumb further deterioration. Thank you very much for listening to me, and thank you very much for having me here.
Thank you very much, Godfrey. Let's put our hands together once again for Godfrey. Do you want to know what I picked from Godfrey's presentation? I'll tell you tomorrow. We need to go back to our breakout sessions, but I am aware that a few of you did not manage to grab your lunch. For those having your lunch, please, the buffet is still on. And before we leave, Dr. Rama, please.
Okay, so we'll be moving back to our breakout sessions, and I would like to request the facilitators to come and stand here so that we can give them hands of their good leading in our sessions. Please, facilitators. Facilitators. These are great people that have come to impact our skills and the knowledge, and we cannot walk without saying thanks to them. And I can tell you, it is multi-hospital, multi-discipline, multi-everything. And I would like to recognize everyone and ask them to speak something and say where they're coming from so that we can understand why we want to knowledge share from each one of us.
Good afternoon, everyone. My name is Dr. Moiz Adamji. I'm an emergency physician. I'm the head of department of Shifa Pan African Hospital. I'm running the emergency department and critical care unit right now. Thank you, and thank you, Ramadhani, for this opportunity. It has really enlightened me, especially Dr. Mpoki's speech. He has given me a new light today. Thank you so much for this opportunity.
Good afternoon, everyone. My name is Dr. Teresia Lutufio. I'm an intensivist at Muhimbili National Hospital, Mloganzila. Thank you, Dr. Ramadhani, for this opportunity. I have met so many people, and I have taken so many points from Dr. Mpoki, especially going abroad, acquire skills. And I think it's important. You go abroad, acquire skills, and introduce those skills to your field here in Tanzania. Thank you. And you're all welcome. I hope we will have other sessions where you will be welcome again. And I hope you're going to practice what we are teaching you here. It's not going to be the end.
Hello, everyone. My name's Dr. Masuma Gulamusen, an emergency physician from Muhimbili National Hospital, the campus in Mloganzila. I'm happy to be here with all of you. For the next 2 days, today and tomorrow, I am an instructor in the PULSE course, and I'm sure most of you who are with me there, we've had a fun time.
Hello everyone, my name is Asha Yulu. I'm an emergency physician from Muhimbili National Hospital, Mloganzila campus. I'm also happy to be here, and thank you, Dr. Rama, very much for this opportunity to be here as both facilitator and also I'm networking with other people.
Hello everyone, my name is Dr. Marco Erasto Nyakasaula. I'm intensivist from National Hospital Muhimbili at Upanga. Thank you so much. You're welcome.
I wear two hats. The first hat, all of you have known me through the first hat, chairman of EMSA, the organizers of this particular symposium. And the second hat, I'm a private physician, a private orthopedic surgeon in private practice. I practice at London Hospital and High Tech Hospital. I used to be at TMJ, now slowing down. Years are catching on. Thank you.
Hello, my name is Winnie Mdundo. I'm also an emergency physician. I work at Muhimbili National Hospital, Mloganzila. I've been there for like 7 years now. So thank you for the opportunity to change the scenery and meet new people and have fun in BLS and Pulse. Thank you.
Yes, good afternoon. My name is Dr. Bita Mwanuz. I'm working with the Muhimbili National Hospital in the Emergency Medicine Department. In this symposium, I'm facilitating basics class. Thank you.
Hello, everyone. So I'm Dr. Shamila Regoshora from Jakaya Kikwete Cardiac Institute, Emergency and Critical Care Unit. I want to thank Rama mkwe wangu for giving me this opportunity. So my request is for each one of you to share this knowledge, as Rama said. Thank you.
Hello, everyone. My name is Ramadan Chaule, working at Muhimbili Orthopedic Institute as an anesthetist. I'm working in the anesthesia department, HDU, EMD, and ICU somehow. I would thank Dr. Ramachunga and Dr. Fire for inviting me in this symposium. And I would like to call for you guys to call others. As you see, this cause is very important to us, and for the other fellows, we used to work with them. Thank you. You are welcome.
Hello, good afternoon again. I'm Dr. Ruben Mkama. I work at Muhimbili National Hospital, Mloganzila, as an intensivist. Actually, in our unit department, we are only 2 intensivists current now in Mloganzila, and we have a team of 4 registrars who are a part of us, and currently we want to start and introducing a pediatric ICU. It has been a privilege for me to be here. I thank Dr. Ramazan and every member here for what we have learned and shared together, but also I thank you guys. We have learned together, exchange ideas, which is something amazing. What I want to say, what you learn here, you know, we should not forget it here. We have to put it in our practice, because you know, as doctors, we have a lot of knowledge, but sometimes we don't use it practically. We're just saying like, oh, this, but you'll be standing far away. So let's practice more and more. Thank you so much.
One more person.
I'm Moses Dabre. I'm from Saifi Hospital. I'm biomedical engineer. I came here for ventilators support. Okay. Thank you. And thank you, Dr. Rama, for calling me. Thank you.
Thank you.
So basically, all of us here, if we can clap hands for Saifi Hospital, has contributed all of the ventilators we are playing with them here, which is a very good multi-hospital team approach. You can see the whole of Muhimbili engine is here. You can see from Shifa, the new hospital coming in. You have seen Saifi is here, and that's the purpose of having SEMC. SEMC, we want to knowledge share among us, because the strength Dr. Fire has, you have heard. The strength Malk has, you may not see Dr. Malk until you get very sick. You want to see him, I'm telling you, this is the only opportunity that you can see him. So let's spend a lot of time asking many questions as you can. And mostly, you won't see me at all until we talk here. So definitely, let's share the knowledge together. Let's show the experience, and we can continue having all these things. So thank you so much, colleagues. I really appreciate for the time that you have invested. I know you may be having a patient today, and you said, no, let me go and impart my knowledge to other colleagues. This is a big investment that we are doing in, and let's continue doing the same. So thank you so much, please, and have a seat.
Thank you very much, Dr. Rama. Thank you very much. Yes, thank you very much, Dr. Rama. I see that you're taking into practice what you're taught today to recognize your team. Now, since I'm also applying the same knowledge, I told you are my mentor, so I'm following your steps. This could not be done possible without the team, organizing team from EMSA, and I would like to recognize a few people in the building. Our favorite uncle, Mr. Kiwanga, please stand and wave. Please, let's clap for him. He's our human resource and administrate manager. We have Ibon Ford, our task team operational head. We have our IT and PR, Jimson, together with Richard. Richard, where you are? Yes, and Jimson. Please, let's put our hands together for him too. Is Mwika around? Mr. Mwika, he's our finance operational manager. And in front of you, I am your facilitator for lunch and iftar. Dr. Edmund Isai. I am also a private. Let's go for our breakout session. I am a private, I don't know what.